Thanks, Jerry, and I think Dr. Zepeda, you'll probably enjoy this talk. I was afraid people will run away when you're a clinician and we talk about quality. I've also put my Twitter account there. If you have any nasty comments about quality, please feel free, because this is free speech. This is my disclosure, probably relevant to CardioMEMS, that I will talk briefly. The objective really is to be a little provocative, because there are, as pointed out in the previous discussions, these are metrics, regulations, which we have no choice at this point. And as clinicians, it's important for us to get involved in these than running away from it. So I'm going to spend some time talking about some thought-provocative controversies, but also the realities and maybe some solutions. And then if time's there, we can talk about our personal experience of how I've been involved in this. But before this, I have a video message, so I'd like you to pay some attention to the video and audio, and hopefully the audio plays.
Now, usually I don't do this, but go on head on DCM with little previews of the readmit. Now, I'm not trying to be rude, but hey, CHF is killing you. Lungs congested up with fluid, well, my census is 32. That's why I'm all up in your grill, trying to get you to a lazy tail. You must be an HMO, the way you'll not be paying the bill. DCM, page you give me that. Bouncing right back to the ER, crackles, wheezing, edema. Why do I rush to DCM? It's like my 10-3 admission, not the sharpest clinician. A CHF patient ought to eat Kentucky Fried Chicken. Soul caregivers the sun, I'm like, so what do you want? There's a freaking picking, all you had to do was manage. Just prevent readmissions, manage those chronic conditions. I'm preparing the handoff, move along to other clinicians. Verbal instructions are clear, only if the patient can hear. Take some freaking tweaking if we're gonna get up into it here.
I think that summarizes my talk. I can probably go home. The whole reason why we're talking about heart failure quality is because it's not that it's a new disease. It's not that readmits are new, but it's gotten into the Affordable Care Act, and I was afraid this is going to be repealed before today, and then I have to delete all my presentation. And that's to come. I'm not sure. I haven't heard any talks about what's going to happen to the quality aspects of it. But the reason why it's being talked about is it's come down to money. And in one way, CMS is smart. Unless we make it about money, I don't think the healthcare industry will respond appropriately. So this year, about $438 million are going to be penalties for all the hospitals, of which 49 will be paying 3% penalty for a readmission penalty from CMS. Now, what does that mean? We talked briefly. It's a excess readmission ratio that CMS calculates based on these 5 conditions out here, of which heart failure is one. But in concept, they're looking at the excess readmission ratio based on a predicted model from national average. And based on risk adjustments, if you are more than expected, your readmission ratio will be excess than 1 in any of these conditions, which will then finally add up to a percentage of all DRGs, which means it's not about heart failure, it's about everything that CMS pays. So that's a good chunk of money that people would lose. And why is it important? Dr. Drasner talked about this. It's about not just about money, but as clinicians, the one good thing that's come out of these penalties is we're talking about hospitalization, we're talking about mortality, which is quite relevant for us as clinicians. More importantly, it doesn't matter how long it takes between admissions and readmissions. The 30 days is just an arbitrary number. So the goal for us as clinicians is to take the right sense of this in one way, that we need to avoid hospitalizations, and more importantly, a decompensation. And Dr. Drasner accurately pointed out, pathophysiologically there's more work to be done, but we know that an acute decompensated state is what we have to avoid, apart from all the quality metrics that we're talking about. What's also important is to recognize the fact that every time they have an acute decompensation, patients' mortality changes and they never regain it back. So the best way of doing it is to avoid the hospitalization, not a rehospitalization, but to focus at a global concept of keep people out of a decompensated state. Now, what happens in a readmission? It's also important to understand because the regulations are here to stay, whether we fight it or not and take it in the right sense. It's important to understand that there is about 40% of these patients are coming back with heart failure. So there is some sense to say, are we doing a good job? Maybe can we do something better? It's always good to question what we're doing as a hospital, as a system, as physicians, as clinicians. But at the same time also acknowledge there is a big chunk of non-heart failure related admissions which might not be related to what you're doing, which you can say it's not my responsibility, but from the payer standpoint, they're considering the healthcare system to be responsible. That's something to think about on how you want to tackle these things. Now, what about 30 days? And why is a fly sitting on my screen? I encourage you to read this viewpoint that was written by Marvin Constam on the heart failure in the lifetime of a housefly. And he very clearly says that it's a focus on all-cause readmissions to the exclusion of mortality, and its focus on 30 days, which is the approximate lifetime of Musca domestica, the common housefly, but a fairly arbitrary and irrelevant time frame in a patient's life, which is important to recognize, but he also acknowledges the fact that you have to pick a number. We talk about 30-day mortality, we talk about a lot of 30-day outcomes. It's a beginning point. Right or wrong, I don't know. It's important to recognize why 30 days is arbitrary, because if you look at data from Everest trial, patients got out of the hospital after an acute decompensation. Greater than 60 days, they had a 56% chance of getting heart failure hospitalization again. So we don't care if we snug the patient in a corner for 30 days, on the 31st day you admit them, you're not going to get a penalty. So it's a concept to remember. Who cares about 30 days? Maybe this is time for us to think about avoiding hospitalizations for the lifetime of a patient. Now, it works. No matter what we can debate, it works because since the monetary penalties have started, a big chunk of the country has started responding. I know the readmission rates have come down. Current readmission rate is at about 21%, which has come down from 23% a few years ago. So no matter what, it's working. And I show this because hospitalcompare.gov gives you information across the board. You can go, I would encourage you to go look at your own institutions. But this is across the medical center, the 3 big hospitals, and they're fairly all doing better than the national average. I'm not going to make a big deal about the 0.1 better we are. But it's there. So the problems with this metric are they're here to stay at this point. The problem also is the fact that it unintentionally intensifies patient diversion. You can stick them into OBS unit, which hospitals did for a while. I think Medicare is catching up to that. You can put them into your office and try to get them out of the ER, but the fact of the matter is they are decompensated. So that's why we got to step back and look at how do you avoid that than just looking at the metric. The other incentives that get distorted are the fact is that you're not looking at the long-term outcomes. We're not bothered about the 60-day outcomes. We're not talking as much as a mortality because we're so focused on the 30-day readmits. Cost saving for the payers. It doesn't make any cost saving for the patients. It doesn't make any cost saving for the providers. In the current traditional model, our hospital is not getting penalized. So if I reduce the readmission rate down to 16%, we're going to lose money. So it's not a sustainable model. There has to be a cost-saving sharing. If I save X amount of dollars for Medicare, how much will I get back from it? I think these are more sustainable concepts. And the tougher part is that there's no clear evidence on what I can do. There's no magic pill. And that's where the whole country is still struggling. But there's been some progress. The question becomes on, is that progress real or is it progress just a number? And that's more to come. And that comes down to the fact of competing outcomes. When you get involved in quality, the reason why clinicians need to get involved is you get the big picture because you know what matters for the patients. This was a classic correspondence that Iran, who I know personally, rebutted because he's in Cleveland Clinic. Cleveland Clinic got dinged for readmissions, and they were very quick to rebuttal back looking at data to show that this graph suggests that hospitals which have lower 30-day readmission actually have a higher mortality rate. And it makes sense conceptually. I did a satire session at Heart Failure Society of America making a joke out of this that, you can have a Gambini intervention and hire the mafia to kill your patients and they'll never come back. And it's important to the message point of that was the fact that if a patient goes home and they die and they never make it into your hospital, you will look good on paper on this metric. But unless we go back to the grill, look at the mortality of 30 days. That's also important because hospitals typically are able to easily generate inpatient mortality, which is important. I don't minimize it. But the 30-day mortality lags because you don't have internal data. By the time you get it from Medicare, it takes a while. So that's competing outcomes. And that's also important to acknowledge for us as physicians. And again, the mortality is also available. I'm not going to point out the difference, but we're all better than national average. But this is this is 30-day mortality, not inpatient mortality. Now, moving on to length of stay, which is also a metric that's talked about in the concept of efficiency to healthcare. And this is always a debate back and forth where, how does what part of length of stay are we responsible for? Because if you look at the treatment process is only a part of the hospital stay for a patient for heart failure. But end of the day, it is an efficiency metric which is cost saving for the system. Sometimes we as physicians go back at night and say, oh, why am I talking about cost? I should do the right thing for the patient. But I think these are days where you have to be fiscally responsible. So no one's encouraging us to send patients out of the hospital if they're not ready. But I'm sure we can all confess that there are things as a system that can be smoothened, that can be increased, pathways and diuretics. So these are things which are important to accept at the same time resist. And that's a tough balance because, as I said, no one's done a study, I would love to do that, but the subconscious behavior change of physicians when you breathe down on length of stay, when you breathe down on readmissions, is it happening? And I'm sure it is. I've caught myself trying not to readmit a patient, but at the same time I have to shake myself up and saying, this guy's sick, he needs to come in, and he ends up getting a VAD or transplant. So it is a moral responsibility, not just for the patients, but it's also a moral responsibility for the healthcare system we're a part of, and we have to accept that. The competing outcome story gets also interesting. I think it's stuck. Can you guys advance the slides? Yeah, it also gets interesting because when you look at countries across the board, when countries have higher length of stay, their readmission rate is lower. So that again is a competing outcome, because if you keep a patient in long enough that you diurese them and make sure they reach their dry weight, they probably won't come back. If you send them out early and you want length of stay, maybe they'll come back. So unless you have systems which factor that in. So what's the solutions? I don't have a magic bullet, because if I did, I could have retired probably by now. The problem is nobody has the magic bullet. I think it's, there you go. Nobody has a magic bullet because, all right, thanks guys. The Rob Kosiol did a study on institutions that have signed up to get with the guidelines as a part of AHA initiative, and concluded all the efforts towards readmission rates were not that successful. So his final conclusion was, although more complete discharge and transitional care processes may be modestly associated, most current strategies are not associated with lower readmission rates. And in my personal mantra for this is really been that go back to the basics and try to assess and analyze what we need to do right. And what does that mean? On the inpatient side, have appropriate guideline-directed medications, and that's something that no one mandates, but those are core measures that we talk about. Adequate decongestion, both in the hospital and out of the hospital, but more importantly, the rest of the list, which sometimes are not very interesting for physicians, for cardiologists. I mean, I didn't do cardiology fellowship to talk about social factors, right? But these are important for us to recognize that you have exacerbating factors, patient education, self-care, identification of end-stage heart failure patients so that you can either talk about bad transplant or palliative care appropriately, comorbid management, and giving importance to the discharge process with an appropriate follow-up. This kind of encompasses what's called as disease management. Now, beyond that, what can we do for decongestion, right? Because that's really the crux of hospitalization. If you look at all the medications that we put people on, you look at the number needed to treat, including Entresto and ivabradine, which are new medications, the number needed to treat to avoid a hospitalization is decent, but nothing remarkable compared to the future of hemodynamic monitoring, which is a PA pressure sensor in the Champion trial, which gives you an ability to decongest people effectively. And just a brief mention of what that is, because it's a newer technology, is the fact that you're able to implant a small PA sensor, patient goes home, which is wireless, and you're able to transmit your PA diastolic so that effectively you're able to effect the decongested state, because we know that volume buildup can happen at least 30 days before the hospitalization. So there are newer tools that are coming up beyond medications, because I've always sat down and argued with our quality officers saying, you can't expect people to go on beta blockers and just because of that not come back into the hospital, because that's not what beta blockers were designed for. So none of the guideline medications decrease your readmission rate effectively, but they remodulate the patient and do better. Now, we're talking so much about 30-day readmissions that you have to go back and question if your institution has the appropriate core measures or not. And we've done effectively lowered hospitalization with the CardioMEMS program, and the national data is actually coming out in ACC about decreasing hospitalizations at a hazard ratio of 0.33 because it's focused on decongestion. Quality assurance as an outpatient. How many practices across the country have an outpatient quality assurance that you're monitoring beta blocker use, AC inhibitor use, right? It's not a mandate. That's what prevents people from getting decompensated. That's what prevents people from dying. And until that aspect of quality comes in, we're probably never going to achieve an ideal healthcare system. Also important is the metric, and this reflects a controversy which I wasn't aware of until I got involved, that CMS metrics. At this point, the only core measure by CMS is echocardiogram. You don't have to monitor AC inhibitor. Beta blocker never got into CMS guidelines. So if your hospital is only reporting the CMS core measures, you will look stellar because everybody gets echo. We probably gel the hell out of the patients to feel better. But what's important is knowing that, and we had to push and subscribe to get with the guidelines, which is a more comprehensive core measures, because until then, we were looking good on paper. Because everybody says, oh, you're 100% core measures, but what are the core measures? So it's important to reflect back and get involved and know what your metrics are. Now, disease management strategies are a concept which needs to be tailored to the disease that you're talking about, but the objectives are to be a systematic approach, including guidelines, breaking the boundaries between medical specialties. 50% of our heart failure admissions are under hospitalists. And if I'm sitting here and making a cardiology-focused area, it's not going to work. The hospitalists need to be involved. And the same thing about after the hospitalization, taking responsibility of that should be a part of it. The Heart Failure Society puts a list of things that you have to do, which includes what we talked earlier about self-care and also having a follow-up appointment appropriately and associating social and financial concerns for these patients. And there's a big list of things that you're expected to do to promote education and self-care. And interestingly, if you look at Hospital Compare, this is a question which talks about how much do you understand your care when you left the hospital. And no matter what we look at, the national average is 52%. So people are leaving the hospital, half of them don't know what meds they got, and probably about 65% here have no idea about the medications, and about only 52% felt confident that they knew what happened to them in the hospital. So we don't have enough systems to engage them, and you expect them to go home and then take care of themselves. It's not going to happen. So you have to invest in things which will modulate this particular thing. Focusing on transitions of care is also an important aspect of handover, and we see disasters once you collect data. Patients go home, they don't know what to do with their prescriptions. They come back to our post-discharge clinic and they have a bunch of prescriptions they've never filled. And it's just the complexity of the system. If you don't look at it, you'll never know. And the post-discharge clinic, a 7-day appointment, is a quality mandate from Heart Failure Society and Get With the guidelines. And there's a reason for this. There's a post-hospitalization syndrome, both physiologically and the errors that happen when you leave the hospital. And if you don't catch it early, they're going to go and come back. That's why the non-heart failure things can range from Coumadin mishaps to overdiuresis to medication reconciliation. And it's important to have a structured 7-day follow-up. And that's always a debate. If they come to my clinic as a busy cardiologist, no matter I see them in 6 days, I don't have the time nor the structure for me to sit with the medications, reconcile. So the concept has been maybe this should be a hospital-based clinic. And I don't think there's any recommendation from that, but that's something to think about. But the avoidable readmissions really focus around things like medication errors, handoff communications, hospital to home and discharge planning, and the physician assessment is a small part of it. But if you're not engaged in this process, you really don't know what else is happening up here, because you're just letting the patients go around with a heart failure which is being affected by other aspects of their health. I think I'm short on time, but I'm just going to quickly show the fact that we went through this process at Houston Methodist with just the idea that this is what happens in heart failure when a patient comes into the hospital. You're across many specialties, many floors, and the focus is only on treatment of Lasix, different shapes reflecting different kinds of care. All this is kind of a ghost because you don't get paid for any education. And end of the day, the goal is to standardize it with the SUNS or a disease management approach, where every patient who comes to your hospital should be getting a standardized care, no matter who sees them and who touches them. And with that in mind, we have a disease management service with a lot of involvement from the quality department and the administration, where we have 2 nurse practitioners and a nurse. We're looking for a heart failure nurse for the clinic. But the goal in the inpatient is to assure education and guideline-directed treatments along with follow-up. And outpatient is to focus on post-discharge visits, urgent follow-ups, and guideline-directed medication up titration, because people go home on codec 3.125 and they can stay like that for a year, because you might not have time to see them back on a weekly basis. And these are services which will improve the outcome on the long term for patients. I'm going to skip these data that we have, but these are templates that I'm happy to share with people that we've used to focus on advanced heart failure and cognitive impairment. And our pilot study that we did for the patients with an age of 65, majority Medicare, who've been in the hospital many times, had a 29% cognitive impairment, which is a whole other discussion when people have cognitive impairment. You can't sit and educate them, they're not going to learn anything. And what we also found was a high proportion of advanced heart failure in these patients, which is something important to remember when you're screening people, followed by a significantly high knowledge deficits despite patients coming in. And on summary, with this intervention, we were able to reduce the readmission rate. Of course, the length of stay is a little up and down because this is not tailored towards length of stay. It's a whole other strategy. But more importantly, what was very interesting to note was we asked 2 questions with a Likert scale at baseline to see how comfortable they were about the disease and how much they knew about self-care. And it was a dismal baseline. After the intervention, the same patients were called, and then you can see the shift of about 75% of them and 67% of them really understanding what they're supposed to as individuals. So a simple education intervention might be enough to do that. This is just a summary of it. It also improved patient satisfaction, which is like a nice tone for the administrators to hear, but it makes sense. Somebody sits down, talks to you about heart failure, your tones, you're definitely going to feel happier about it. So with that overview and thought-provoking statements, hopefully not too extreme, the urge is really quality is everybody's responsibility. instead of talking bad about the metrics, we might have to reshape it and get involved. And as Dr. Zepeda pointed out, it is a responsibility of us as clinicians not to let this ruin the outcomes, but to get involved so that you can monitor it and tame it appropriately. Thank you.